Sarika. That was an excellent talk summarizing some of the key issues with investigating patients for hematuria. I'd like to now invite Nikita Bhatt, who will give us a presentation on how to perform a good quality TURBT. Nikita is a specialist registrar in Norwich. She's also currently the vice chair of BURST, which is the research wing for trainees in British Urology. Nikita, if I can ask you to take over, please. Thank you.
Thank you. Thanks, first of all, for having me today. Just going to share my screen. Okay, so can you see that? Is that all right? Good.
Yes, we can.
Great, thanks. So I'm going to talk about performing a good quality TURBT. I think TURBT is one of those procedures that we do in urology as a core procedure that definitely affects outcomes in patients, and the quality of this procedure especially tends to affect how patients will do during the course of their cancer treatment. This has been summarized in all the guidelines that TURBT is an essential step in the management of non-muscle invasive bladder cancer. You perform a proper TURBT by pathology investigation as a diagnostic procedure and an initial treatment step. I was watching one of the webinars from UCSF recently, and I really like this slide from there, which I've put here. If TURBT was invented in this era, they'd probably describe this as something like a focal, targeted, personalized, single port, natural orifice, scope, no scalpel, minimally invasive technique to treat non-muscle invasive bladder cancer. And hence, it should be done well when you're investigating your patients at the beginning of their journey. So I'm going to go briefly through the steps of TURBT and then talk about our study ReSect that really deals with the quality of TURBT towards the end. So the steps of a TURBT include a bimanual palpation under anesthesia, which is really important and quite often forgotten step when you are starting off the procedure. Then it involves insertion of a resectoscope, visual inspection of the entire urethra, inspection of the urothelial lining of the bladder, if indicated, the biopsy of a prostatic urethra, which I'll go through, cold cup bladder biopsy if indicated. Then you resect your tumor, you record your findings in your op note, and you ensure that you have a precise description of the specimen for path evaluation. So I'm going to go through all these steps in detail now. There's now growing evidence, and it's involved in the guidelines, that we should try and use adjuncts with white light TURBT. And the options available at the moment include PDD, which is instilled into the bladder about an hour before the procedure. This is absorbed as a hexaamino-level unit, and it's converted into protoporphyrin 9 and shows up as red fluorescence or illumination with the blue-violet light, and as you can see in the pictures here. And the other thing that we can use is narrowband imaging, which uses blue and green spectrum of light to improve the visualization of flat areas in the bladder that may not be otherwise that obvious on white light. There is evidence to show that PDD has improved sensitivity at both patient level and biopsy level. However, it does have a lower specificity. It has also been shown to lower recurrence in both short-term and long-term. However, at the current moment, we don't know the effect on progression and mortality. Resection type originally used to be piecemeal is what we were doing, but there's now growing evidence about en-bloc dissection, and this includes using either monopolar, bipolar, or laser in select exophytic tumors, as you can see here, to resect the entire tumor en bloc. There is evidence to say that with this sort of a technique, you can get high quality specimen and you can achieve detrusor in about 96 to 100%, which, as I'll come to on the next slide, is quite important. Bipolar resection has been introduced, and there is some theory that it can reduce complications such as bladder perforation due to obturator nerve stimulation. but this is controversial. Certainly, increasingly in the centers I've worked in, we've started using bipolar resection. Again, to avoid cauterization of the base, to ensure that you've achieved good muscle from the base before you do that. And the guidelines would also suggest that for small papillary recurrences, outpatient fulguration or laser vaporization is equally safe as resecting them, especially in elderly or comorbid patients. So detrusor muscle, I'm sure everyone is aware of this, and something that's been really driven home by all guidelines is to obtain detrusor during TURBT. And why do we do this? It is because if there is no muscle in the specimen, you're at a high risk of residual disease, early recurrence, and tumor understaging. There's a lot of evidence for this. For example, when detrusor is present, the residual tumor rate is about 20%, but when absent, it's nearly 51%, and this is really significant. Biopsies, usually you try and take biopsies from red patches or abnormal looking urothelium around the tumor. Mapping biopsies you can take if the cytology is positive and the cystoscopy is normal. Increasingly, however, with PDD, you can see these areas quite well, so the mapping biopsy role has reduced. Prostatic urethral biopsies, again, for things like bladder neck tumors, suspected CIS, if there's a positive cytology or there's abnormalities in the prostatic urethra that are visible. And the way this is done is you go at 5 and 7 o'clock in the precollicular area and use a resection loop to take these biopsies. And the reason is about 40% of patients with prostatic urethral involvement will have this an invasive disease, and this can be easily missed. And it is an important predictor of invasive disease, especially if there is a stromal involvement in the prostatic urethral biopsy. This tends to upgrade the tumor from a non-muscle invasive. And then the next step is documentation. This is also key and has been emphasized in all the guidelines. There are certain things that need to be there on your op note when you're doing a TURBT, and these include the size and number of tumors, the adequacy of resection, whether you've achieved a visually complete resection, have you seen muscle at the resection base, presence of complications, especially if there's a perforation, and then you try and measure the tumor size. The way you do this is the use of your end of your cutting loop is approximately 1 centimeter, so you use that as a reference. Then you describe what was the nature of the tumor, sessile, nodular, papillary, or flat, and if they've had any previous treatments such as intravesical treatments or radiotherapy. Again, similar things you want looking for in a pathology report in your MDT are tumor location, tumor grade, stage, lymphovascular invasion, unusual histology, presence of CIS, and detrusor muscle, which will all impact how you decide the risk category of this tumor. So all of these are important to be documented in the op note and the path report. Reresection, again, it's something that is quite evidence-based. The first evidence for reresection came from her, who works in Memorial Sloan Kettering in 1999 in the Journal of Urology. Since then, there have been a number of studies showing why this is important. So the guidelines would suggest that you perform a second TURBT after you've had an incomplete initial TURBT, or you're in doubt that you haven't completed the resection, or if there is no detrusor in the specimen except in low-risk tumors and primary CIS, and in all T1 tumors. You ideally perform it 2 to 6 weeks later, and you try and resect the primary tumor site. And in the pathology report, you mentioned it's a reresection. So a recent systematic review with over 8,000 patients showed that there was 50% risk of persistence with TA or T1 high-grade tumors, and 8% risk of understaging in T1 tumors. So this is clearly an important step in TURBT. And then the last step as you're completing your TURBT is to think about whether you want to give intravesical treatment or not. Intravesical treatment is usually in the UK, we've been giving mitomycin. You can also give epirubicin. You try and achieve this sort of intravesical treatment within 6 hours of your primary resection, and this has shown to reduce your 5-year recurrence rate by 14%. From 59 to 45%. There's some growing evidence about gemcitabine, but the results are quite mixed. So who should receive this is for intermediate or risk or primary tumors with a recurrence rate of less than 1 recurrence per year, or an EORTC recurrence score of less than 5. You can also give this for presumed low-risk tumors and small papillary recurrences over 1 year after their previous TURBT. Giving intravesical treatment will impact on the recurrence even with further adjuvant chemotherapy installations, for example, BCG. So this is important, especially if you think that your tumor is low risk or intermediate risk at your original resection. This will also, the theory is that the intravesical treatment reduces implantation of tumor cells after your BT. To achieve improved compliance with intravesical treatment, we try and give this during the resection itself. So immediately post-operatively in theatre, it's given by the surgeon, because there is some evidence to show that if you leave it to the nurses in recovery, for example, or in the ward, the compliance is lower. So if you look at all the evidence on TURBT, there is growing evidence that despite all our best efforts, whether reresection or intravesical treatment, there is a lot of variability in bladder cancer treatment. So there's something else going on. And Brozzi did this study in 2002 who said that there's a lot of variation in the recurrence risk after the first cystoscopy, So clearly there is more than just giving intravesical treatment or following guidelines. Mariappan in 2012 found that TURBT surgical quality makes a huge difference. So there's a lot of variation, for example, in the Scotland quality indicator study that showed that if you achieve a lot of variation in detrusor presence or absence or giving intravesical treatment, the quality of TURBT was extremely variable. So they did a study in Scotland over 2014 to 2017 to show that the recurrence rate was different based on the TURBT quality. And even telling people that their quality of TURBT was different or wasn't up to speed changed the recurrence risk, which is why there has now currently been a lot of focus on improving TURBT quality. It has been recently called as a neglected procedure in the technology race in bladder cancer. There's a lot of energy and focus now on improving TURBT quality, reducing variation in practice so that the recurrence risk at the first cystoscopy is at least comparable across different centers. With this in mind, Burst is launching Resect, or we've already launched it, and it's currently recruiting patients. So Resect is to determine if audit and feedback can improve the quality of TURBT surgery and reduce early recurrence. What we are trying to do is launching audit and feedback into the digital age. To take part in this study, you need to be a center that performs TURBT for non-muscle invasive bladder cancer and submit only 25 prospective and retrospective cases over the course of a year. You recruit consecutive patients undergoing curative treatment. You register your study and you start retrospective collection first. You enter data about TURBTs performed before the start of the study. We will then give you feedback on how your centers are doing, very similar to the QPI data. And then we will ask you to collect prospective data after you've received this feedback to see if whatever feedback we are giving you is improving your performance. And then we'll follow up the data about the RETUR, first check follow-up, and at the moment we're only following it up for less than 6 months. The primary outcome is we're trying to see if people are achieving key TURBT quality indicators, which we will make clear at the feedback stage. And the secondary outcome is early recurrence rate at less than 6 months. Again, it's only 25 studies, out of which only 20 need to be new tumors, and you can have a minimum of 3 authors with this sort of authorship requirement. You can include more authors, and by collecting 10 more patients in each retrospective and prospective phase. So this is essentially what we wanted to build is a tool for you and your team to see how you're doing compared to different centers in the world. So we've got international recruitment, again, such as Identify, all around the world. All your data will be anonymized. You can look at your data filters live as you go along and try and improve the quality of TURBT if necessary. So it is based with REDCap. So all you need to do is first ensure you've got ethics, then you collect the TURBTs, identify the cases from the previous 6 months, you screen them, enter them on REDCap, we give you feedback, and in the end you identify deficiencies and improve. So we've already launched this study, but if you haven't taken part and you would still like to get involved, you can email us on this email ID. And yeah, participate. Thanks very much, and thank you for inviting me to talk.
Thank you very much, Nikita. That was an excellent talk on the quality on TURBT. And we look forward to the results of ReseCT in due course.